So here starts our Osce. What are the two main types of oximetry and what do they measure? This is about pulse oximeter.
And co-oximeter.
Oximeter and
It measures
Oximeter.
carboxyhemoglobin, sir.
What are they called? Is there any specific name? One is called the fractional oximetry, which is also called as co-oximeter. Okay, can only be measured by an arterial blood sample. It measures oxyhemoglobin, deoxyhemoglobin, methemoglobin, carboxyhemoglobin, and also arterial oxygen saturation. Okay, so it is mentioned as SaO2. Actually, this only should be called as SaO2 because many of us have the habit of writing, or even our regular pulse oximeter probe which we put and measure, we have the habit of writing SaO2. That is not correct. SaO2 should be measured only by fractional oximetry or co-oximeter. Then it measures the arterial blood, not the capillary blood that we normally see at the periphery. So the other is called the functional oximetry, which can be measured non-invasively by a standard pulse oximeter, which measures only the oxyhemoglobin and the deoxyhemoglobin. So the SpO2 is a functional oximetry. If you write SaO2, it indicates fractional or co-oximetry. Correct? Did you all know this point before?
No, sir. No, sir.
Okay. So what is the accuracy of pulse oximeter? Why is it not accurate below 70%? When the patient saturation is below 70%, will it be accurate?
No, sir, because it is extrapolated using real time data from real human beings. So
normal individual. Excellent. The SpO2 between 70% and 100% is accurate within 5% range. Okay. Whereas if it is below 70%, it is not accurate because the calibration of the pulse oximeter is done with healthy volunteers whose SpO2 will not go down to this level. Okay, that is the reason why whenever you find the saturation below 70%, it may not be accurate. Okay, very good. Okay. What is dyshemoglobinemias? What are dyshemoglobinemias? What will be the saturation in those conditions? I thought instead of asking the regular what is the wavelength of oxyhemoglobin, deoxyhemoglobin, what is Beer-Lambert's law, I thought I will ask some questions which will kindle your interest in reading more. What are the conditions? This hemoglobinemia, you know, or
Methemoglobinemia, sir.
Methemoglobinemia, sulfhemoglobinemia,
hemoglobinemia, sickle cell anemia. So sickle cell anemia is in a vascular occlusive crisis can have inaccurate SpO2 reading. Okay. In patients with high level of bilirubin, will it affect the saturation? Supposing bilirubin is 11 milligrams or 12 milligrams, as I showed in obstructive jaundice patient, will it affect the SpO2 reading? Answer is only yes or no.
Yes.
Till now,
Yes,
it does not alter the SpO2 readings. Okay. In case of carboxyhemoglobin,
Yes, sir.
alter, sir.
will it show normal value or it will show a false reading?
Falsely accurate
reading.
Falsely higher reading.
Higher reading.
Okay, measures as 90% as oxyhemoglobin and 10% as deoxyhemoglobin. So thus when there is a higher amount of carboxyhemoglobin, it will overestimate SpO2. Falsely high oxygen. Okay. So in patients who have been rescued from a closed fire situation, if you measure the SpO2 and it shows 95%, it is not the real. It will be having more of carboxyhemoglobin than oxyhemoglobin, and you will be hypoxemic. So don't depend on the SpO2 in patients exposed to carboxyhemoglobin. In cases of methemoglobin, what will happen?
Estimate the saturation.
Underestimate, excellent. Absorbs equal amounts of red and infrared light. So SpO2 will be red as 85%. Very good. What are the causes of methemoglobinemia? Now that we have seen these changes.
Cyanide poisoning, sir.
Cyanide poisoning. There are several causes. Okay? Not only cyanide. It can be because of nitrates, can be local anesthetic like benzocaine or prilocaine, chlorates, anti-malarials, anti-neoplastic, sulfonamides, dapsone, metoclopramide. Even metoclopramide can be a culprit for methemoglobinemia. Okay? So these are all the things that we have to know. How was the name dexmedetomidine coined? Is there any other compound named in the same way? A drug which we are commonly using nowadays.
Dextroisomer of medetomidine.
Excellent, very good. It is medetomidine is the main generic name of the chemical compound, and it is a dextroisomer. So dextroisomer of medetomidine was found to be an active compound. So this name was coined using the dex in the dextro. So medetomidine plus dextro, dex from dextro, dexmedetomidine. Which other compound has got the name similarly?
Sugama dex, sir.
Sugama dex, yeah, dex comes at the last. Okay, I agree with that. But a very commonly used IV fluid. Commonly
Levobupivicaine.
dextrose, solution was named the same way. Dextroisomer of glucose is called dextrose. Okay. What is the chemical name for dexmedetomidine? Very difficult, but you have to remember that for exam's sake, it is a 2,3-dimethyl phenyl ethyl 3H imidazole. Okay, so it is an imidazole compound. What other imidazole compound we are using in our anesthesia practice?
Antibiotics, so metronidazole is an imidazole compound.
Imidazole, anesthesia practice.
Ketamine, sir.
Ketamine is not an imidazole.
Intermediate.
Etomidate,
sir.
yes, etomidate, we have already discussed. Etomidate is an imidazole. Very good. What is the mechanism of action of dexmedetomidine?
Alpha 2 agonist.
Receptor agonist.
Which alpha 2? All alpha 2 or selective? The highly selective potent alpha 2 agonist with alpha 2 is to alpha 1 affinity ratio of 1600 to 1. Okay, so it is a selective potent alpha 2 agonist, mainly acting on other drugs may also act on alpha 1 receptor also, but this is a selective alpha 2 agonist. What are the subtypes of alpha 2 agonists in their actions?
Alpha 2 A, B, C, sir.
Hmm.
A in brain, B in spinal cord, and C in sympathetic.
Very good. Okay. So subtype A acts on CNS, responsible for sedation, analgesia, and symptolytic effect. B is in peripheral vasculature, not in the spine, with short-term hypertensive response. C is in the again central nervous system as an anxiolytic effect. Okay? So these are the three subtypes. Why should dexmed be avoided in microsurgical procedures?
Due to bradycardia.
Bradycardia can be connected with
Hypotension and anastomosis is difficult to maintain.
anastomosis, or what is its
The
effect?
microcirculation is affected.
How? See, in microsurgery, what you do? You dissect out the tissue along with the blood vessel from one area, cut off the vessels, and then re-anastomose it to another vessel in the distal area, isn't it? So what will be the response if you cut off the vessel? Will it be responding to the nervous stimulation? It is a denervated vessel, isn't it? Even when you do a kidney transplant also, it is a denervated vessel. Okay? So it causes vasoconstriction in denervated arteries. right? And so it will not allow the perfusion to happen in the microsurgical tissue. Is it possible to reverse the effects of dexmed? Supposing you are given overdose of dexmedetomidine, can you reverse the effect? Is there any drug?
Sugammadex.
No, sir, one drug is available, but it is not approved for FDA.
Not approved. What is the drug?
Sugammadex.
Not approved. Acipamazole, an alpha-2 antagonist, which can reverse the effects of dexmed, including analgesia. So it is called acipamazole. What is the new applications of pulse oximetry? Are there any new applications other than just measuring the saturation? Can we use pulse oximetry for some other
Perfusion index.
Huh?
Perfusion index we can
Perfusion index.
perfusion index.
That is part of the display you are getting it. New
Yes.
application.
Fluid status and
Continuous
using the
cardiac
pleth of the
pressure.
You can
Cardiac
use
output monitoring.
plethysmography to measure the volume status and fluid responsiveness. Very good, number one. They are also used during epidural test dose administration to detect intravascular injection. Okay? So when you are giving epidural test dose with xylocaine and adrenaline, you can use the pulse oximeter to find out any changes in the heart rate as well as the saturation. What is the use of mixed venous oxygen monitoring? MVO2. What do you search by that?
it can display the cerebral perfusion index,
Cerebral perfusion.
like jugular venous pulse saturation.
Okay, why do you want to measure the mixed venous oxygen saturation first of all? If you understand that, you will be able to answer this. Why you want to measure the oxygen level in the mixed venous blood?
Any shunting, sir?
And
Okay.
hypoxia, to check hypoxia.
How much of oxygen should be there normally in the venous blood?
75.
75%. Okay, 100% in arterial blood, 75%. That means 25% is taken up by the tissues and returned with 75%. So if more reduction is there, what does it mean? Tissues are extracting more oxygen. They are in dire need of oxygen. They are trying to extract more oxygen for their survival. So a reduction in SvO2 indicates global tissue hypoxia. Okay? And pulse oximetry combined with continuous SvO2 measurement in patients with acute respiratory failure can also find the shunt fraction and help in ventilator adjustment. Okay? What is the purpose of expired gas analysis? Nowadays, all your workstations come with values of expired EtCO2, EtO2, ET gas values. Everything comes in your new machines. What is the purpose? Helps to assess the depth of anesthesia by making inference about the blood concentration. Okay? So, what will happen to your oxygen? Will it be same? When will you say pre-oxygenation is adequate?
When ETO2 is more than 90.
More
Greater
than
than 90.
Inspired oxygen level and ETO levels are almost equal. Then you say patient is 100% pre-oxygenated. Similarly, if you give a gas until the saturation becomes equal, that means the patient is still in the stage of absorbing the gases. Okay, so it will be an indirect measure of depth of anesthesia. What techniques are used for gas analysis?
Spectroscopy, sir.
Lot of techniques are there. So mass spectroscopy is one. Anything else you know? So mass spectroscopy, infrared absorption, electrochemical analysis, paramagnetic analysis, and nitric oxide measurement. Okay? All these things. What is the waveform shown here?
Capnographic.
Capnogram.
Then capnograph or gram or what? This is a normal capnogram. Okay. What do alpha and beta angles of capnogram denote? What do what do they denote? One of the common questions in the exam. Why you will have to answer this.
So the alpha angle is the
Hmm.
takeoff angle, sir.
Takeoff angle. Okay. What does it indicate?
Peak expiration and beta angle indicates
Beta
Alpha
increase
angle primarily linked to variation in time constants within the lung. It's an indirect indication of VQ status of the lung. There is ventilation perfusion status. Okay, whenever the ventilation perfusion status is affected, this angle will also be affected. Similarly, beta angle is
Internal CO2.
extent of rebreathing. Okay, if supposing the amount of carbon dioxide is more, this will go on be going up and it will become wider like this. Okay, normally it is about 90 degrees. It becomes 110, 120. That means patient is rebreathing carbon dioxide and the level of carbon dioxide will be elevated. Okay, so that is about it. I am showing a few pictures. What is shown in these pictures? It's something related to the previous last question.
Mainstream capnography
CO2
and
analyzer, sir.
Ah,
Mainstream
this is
stream.
the mainstream capnography instrument. This is the side stream sampling tube. Okay, to the adapter filter tube. So ETCU measurement, mainstream versus side stream. What is shown here?
Spontaneous.
Spontaneous. There are two pictures, A and B. What does A show? What does B show? What types of capnograph are these? What is A? What is B? What are the types of capnograph used? Have you not heard of volume and time capnograph?
Yes, sir.
See, capnograph, time versus volume capnograph. Which is time, which is volume here?
Sir, A is time and B is B and C volume, sir.
B and C volume. How do you say that? What is the difference between the two?
In the x-axis we have time, sir.
Hmm.
Here we have volume, sir.
Hmm. Is there a inspiratory drop here? Which is only measuring the entire CO2. Is there any drop in the CO2 here? So the difference is there is no inspiratory segment in volume capnograph. Okay? Whereas it has got the inspiratory segment also. What are the advantages of time capnography? This is time capnography. What are the advantages over this volume?
Both inspiratory and expiratory segment.
Simple and convenient, number one. A non-intubated patient also can be monitored, whereas volume you can do it only in intubated patient. It monitors dynamic inspiration as well as expiration. What are the disadvantages of time capnography? Poor estimation of V2 status of the lung cannot be used to estimate the next stage component. What is depicted in this picture?
Sir, epidural.
Hmm?
Epidural.
Epidural. See, you are seeing
Paravertebral
some,
muscles, sir.
huh?
Paravertebral muscles.
Thoracic.
Paravertebral muscles, correct. But how to describe this picture? It is the cross section of abdomen at L4 vertebral level. Okay. They have taken a transverse section of the abdomen on the L4 level. What are the structures that are being marked here in short form? What is PA?
Oblique internal, transverse
Transverse
abdominis, internal
Ah.
oblique,
Oblique,
external
external
oblique.
oblique.
Three
Latus
muscles of
muscle.
the anterior abdominal wall. What about this?
Yes, sir.
Latissimus
Latissimus
dorsi.
dorsi,
Quadratus lumborum.
lumborum.
Psoas major, erector spinae.
erector spinae.
Okay, right. So these are all and L4 vertebra also. So what is shown in this ultrasound image?
Quadratus lumborum block, sir. Ultrasound guided quadratus lumborum block. With the
Ultrasound.
landmarks.
But there are so many 12B1, 2, 3 intramuscular, so many needles are coming.
Different
Blocked
approaches.
by different approaches. Yes, needle insertion for various approaches to quadratus lumborum block. What is the sensory supply of the abdominal wall? Which segment to which segment? Thoracic
T4
or
to T10.
T6.
T7 to T11.
entire abdominal wall from the clavicle level to the waist level. That is the abdomen, isn't it?
T7 to
So
T12.
lower thoracic, 7 thoracic, T1, uh, 2 first lumbar. Okay. So, but 7 means actually it should be T5 to L1. Okay. That's why you check up to the people for T4, T5 for your
Higher levels.
final after the for pregnancy. Right? When you do a cesarean section, you want it to go up to the nipple level, T5. What are the indications for quadratus lumborum block?
Bowels resection, sir. Laparotomy.
Laparotomy.
Mastectomy, appendix.
Can you do a laparotomy with quadratus lumborum block alone?
Bone marrow aspiration.
No, sir.
You can do all these surgeries like abdominal laparotomy, abdominoplasty, open laparoscopic appendectomy, cholecystectomy. Obstetric gynecology can do cesarean, total abdominal hysterectomy. Urology can do prostatectomy, can do iliac grafting hip surgery. Okay. What is the main difference between tab block and quadratus lumborum block?
Tab block anteriorly.
Fuel does not
Will
cover the
circle
midline
exposed.
areas.
Any other answer? Tab block, can you do cesarean?
Only sensory.
Yes, sir.
Somatic sensation only will be blocked by tab block, whereas visceral and somatic will be blocked by quadratus lumborum. Okay. So quadratus lumborum provides somatic as well as visceral analgesia of the abdomen, whereas tab block may provide only extended sensory blockade between T4 and L1. Can be used as an adjuvant. But quadratus lumborum per se cannot be used as a sole anesthetic for surgery. It can be only used as an adjuvant because it has an extensive coverage. What is shown in this picture?
Video
CMAC.
laryngoscopy.
Vocal cord.
Video laryngoscopy. Video laryngoscopy used for intubation. What is a video laryngoscope? What are the parts of the video laryngoscope?
Video assisted intubation.
Oh, I must. This is the second question. What is the video? What is a video laryngoscope? Is it a directly intubating instrument or an indirectly intubating?
Direct, sir.
Direct. Direct means you are learning. The Macintosh learning scope is very direct, where you bend down and look at the vocal cord by
Directly
yourself.
visualizing the vocal.
This is indirect. See, you are not looking into the throat at all. You are looking at the monitor, isn't it? So video laryngoscope is an indirect laryngoscope. The parts are, all of you are using Mac light
Yes, ma'am.
scope. All these things are you all using it?
Yes, sir.
Yes, sir.
Then you must know the names. Parts of whatever instrument you are using, you should know about them thoroughly. So it has a handle, it has a blade, it has a micro video chip camera embedded at the tip of the blade. It has an external video monitor with a liquid crystal display or LCD display. Okay, so 4 parts: handle, blade, which has a micro video chip, and there is a monitor. Okay, these are the components. What are the advantages of video learning?
It helps in difficult intubation, sir.
Okay,
Minimal manipulation of cervical
very good.
joint.
Two.
Less
Okay,
trauma to the oral mucosa.
okay, 3.
Thick blade, so we need not displace the tongue. We can directly insert the.
Okay. Right. There are several advantages. Improved laryngeal vision, less force required, less cervical spine movement, less hemodynamic response, short learning period, improved portability and cost, useful teaching tool so people also can watch, high success rate, especially in difficult cases. Okay, these are all the advantages. What are the disadvantages?
ET tube passage will be
Difficult to manipulate the endotracheal tube, sir, with the D blade.
So there are lots, just like the other one. Fogging and secretions may obscure the view. Passage of the tube may need a stiller. Loss of depth perception. Economic issues over stock acquisition and maintenance. Greater processing time. Different makes and models need different approaches. Okay, so there are several varieties. And classify video laryngoscope with which are in use, common use, and their examples.
CMAX.
CMAC is a trade name or a manufacturer's name, but to classify them, this is the classification. Video laryngoscope can be with integrated channel laryngoscope, video stimulants, or rigid blade laryngoscopes. These are the 3 major types of video laryngoscope. In the integrated channel laryngoscope, you have airway integrated laryngoscope, which is called C-track. You have the blade image, that is the airway is the integrated channel. You can use only an airway. And the blade, you have a Pentax AWS air track. For the stillet types, you have the rigid stillet, which is called Bonfils. And for rigid blade laryngoscope, you have the standard blade called VMAC and CMAC. And for angled blade, you have glide scope and Hagar. So these are all the varieties of video laryngoscope. What is shown here?
Biomedical waste disposal system.
Color coded biomedical.
Color-coded biomedical waste segregation bins. That is the correct answer. Okay? Don't be in a hurry. Think and answer slowly. What are the sources of biomedical waste?
Anatomical wastes.
Hospital.
Animal waste.
So hospitals, healthcare centers, blood banks, biomedical research centers, these are all the sources of. What is the definition of a biomedical waste?
Something
During
like
waste
waste
generated
produced.
during diagnosis, treatment, or immunization of human beings or animals or in research activity. Okay, so any waste generated during these procedures. Classify biomedical waste.
anatomical waste,
Hmm.
அந்த மாதிரி.
Okay.
Chemical.
Infectious waste, pathological waste, sharps, pharmaceutical waste, genotoxic waste, chemical waste, radioactive waste, heavy metal containing waste, and pressurized container. There are so many varieties of that biomedical waste. What are the steps in the management of biomedical waste?
Collection,
Collection,
segregation,
Collection.
Transportation,
transport and treatment.
Ah. So survey, first the survey of waste generated, segregation of hospital waste, collection and categorization, storage, transportation and treatment. So 1 survey, 2 segregation, 3 collection and categorization, 4 storage, 5 transportation, 6 treatment. So 6 steps are the what items are deposited in these various color coded bins and how to treat them.
Yellow is any human or anatomical waste.
waste.
It is incinerated.
Red is tubings, catheters,
Any recyclable waste goes to red.
autoclaving,
Non-infectious recyclable waste goes to red.
waste needles, sir. Treated by shredding, autoclaving. Black is cytotoxic drugs or medicines. It is in landfills will buried, sir.
So this is the yellow human animal waste, cotton dressing linen, red tubing catheters, IV sets, blue only for sharp waste like needles, scalpel, syringes, black for discarded medicine or cytotoxic drugs. Okay? How they are disposed of is also given. What is apparent?
Derived from parts in
Antipoison.
intestine.
What is the chemical? It's an anionic mucopolysaccharide organic acid containing many sulfate residues which are present in the liver and mast cell granules also. What is its mode of action?
It forms complexes with antithrombin and inhibits factor 2A and 10.
Number, any number is there?
83.
Now, okay, 1. There are 4 modes of action. All 4 we have to describe. So enhances formation of antithrombin 3 and thrombin. It inhibits the factors like 2A, 10A, 12A, and 11A, and also 9A. Inhibition of platelet aggregation, second method of action. Third is release of lipoprotein lipase from tissue. Fourth is increased vascular permeability. All these are mode of actions. Okay? What are the uses of heparin?
Therapy, sir. And for
Used in prophylaxis and treatment of thromboembolism.
embolism prophylaxis.
Used in cardiopulmonary bypass, sir.
3.
Microvascular
Prophylaxis, the treatment of DPT, pulmonary embolism, treatment of unstable angina, timing of extracorporeal circuits, critical peripheral arterial occlusion. All these conditions you can use. Routes of administration, dosages, and the onset of action and duration of action.
Route subcutaneous and intravenous.
IV and SC. Okay. Dosage. It is dosage prophylaxis 5,000 international units, subcutaneous 8 to 12 hours. Full anticoagulation 300 international units per kg or 3 milligram per kg IV. Onset time is immediate and half-life is 40 to 90 minutes. How is its action monitored? What are the tests you will do to
ACT
monitor?
can be done, sir.
Routinely APTT,
APTT.
activated clotting time during cardiopulmonary bypass. What are the types of SIPs? Heparin induced thrombocytopenia.
2 types are there, sir.
2 types.
Type 1, type 2. Just like halogen hepatitis, it's also 2 types. One is non-immune. Occurs after
Type
4
2 is
days.
immune mediated.
No need to stop heparin, you can continue. Whereas type 2,
Mediated, sir.
when will it happen?
after 1 to 2 weeks of the therapy, sir.
10 to 15 days. What is the treatment? You have to stop heparin.
Yes, sir. Heparin must be discontinued, sir.
Discontinued. What is the alternative? Supposing you
Argatroban.
are lepidolin, argatroban, or danaprone. Okay, so it is after 5 to 14 days it can happen. But the alternative is you have to stop heparin and give immunogestion. What is hyponatremia?
When plasma sodium level is less than 135
Very good.
milliequivalents per liter.
Classify hyponatremia and just
Euvolemic hyponatremia, hypovolemic hyponatremia, and hypervolemic hyponatremia.
that is one classification. Any other? So you can classify hyponatremia based on the clinical severity as moderate, and there will be nausea without vomiting, confusion, headache. It will be severe, causing vomiting, cardiorespiratory distress, drowsiness, seizure. Or it can be biochemical classification based on the sodium value. Mild is 130 to 135, moderate 135 to 130, severe less than 135. Or it can be called as acute, with onset less than 48 hours with no time for adaptation with features of cerebral edema. Okay. And how to assess a patient with hyponatremia? How do you go about to assess whether a patient requires treatment or not?
GCS, sir, plasma sodium levels.
And serum osmolality.
Serum osmolality or plasma osmolality? What is the difference between plasma and serum? It's a good thing.
No, sir.
With
In plasma, the concentrates won't be there, sir. Sedimented.
Plasma, the coagulation factors are there. Whereas in serum, you remove them and take it to immediately. Okay? So that is the difference. So you must always say plasma osmolality, not serum osmolality. Okay?
okay,
So
okay, sir.
first of all, assess the plasma osmolality. If it is low, assess the volume status. If the patient is hypovolemic, check urine sodium level. If sodium level more than 30 millimole, it may be Addison's disease, short fusing nephropathy, cerebral saltating syndrome. But if the sodium level in the urine is less than 30, then it may be a GI tract diarrhea, vomiting, evaporation through extreme fluid loss. So you have to correct that status. In euvolemic state, check the urine osmolality before you check the urine sodium also. If the osmolality is more than 100 milliosmol, check urine sodium. More than 30, it can be syndrome of inappropriate ADH secretion, hypothyroidism. If it is less than 30, it is water overload. And the urine osmolality less than 100, it is psychogenic polydipsia. And patients with hyperolemia, it may be digestive failure, liver or renal failure. Okay? So that is the first assessment. Then you check the plasma osmolality, which is normal or high, maybe hyperglycemia, pseudo-hyponatremia due to proteins and lipids. And how it is corrected? How do you correct the hyponatremic state?
Correction should not be given, sir, because there's a risk of central pontine demyelinosis that can happen.
Very good. So treat according to cause, excess water, you remove it, especially supposing PRP syndrome produces hyponatremia because of water dilation. Then you give diuretics, reduce water intake and IV fluid. If it is SAADH, you give erythrocycline, otherwise give normal saline or 3% saline or sodium bicarbonate. What complications already I said it is central loss pontine demyelinated, also known as osmotic demyelination. Safe dose of this is 0.5 to 1 ml per kg per hour and check serum sodium levels periodically to correct it. Not to increase the sodium level by more than 10 millimoles in 24 hours. It is the dictum to prevent this complication. Maximum you can give 10 millimoles per 24 hours. Are you able to identify this? The ultrasound probe is being used. This is the pointer. These are all the things that are marked. So method of identifying the lobes of the lung by placing your hand on the patient's chest. This is the upper lobe. I said this is the middle lobe. This is the lower lobe. Okay. So correspondingly, we will have only two lobes on the left side, so upper and lower lobe. This is the posterior segment. What is shown here? Written here, C sand,
Yes, sir. She saw signs, sir. Lung sliding movements
tongue sliding
in
in
with
the
yes.
normal lung. Okay, so this
Yes.
is a C shore or subcutaneous tissue. C is the subcutaneous tissue, sand is the lung, which is moving, subpleural space.
Barcode sign in pneumothorax. Sir.
Barcode sign in
Pneumothorax. Sir.
pneumothorax, very good. No lung sliding, very good. So this
B lines.
B line,
Three
huh?
lines in pulmonary edema.
Pulmonary interstitial disease. Okay, interstitial syndrome. So what do you see in this? We have three parts in this picture. What is this picture? What is the arrow showing here?
Central line.
Central line.
Cardiac tamponade T2 is placed as
You are not shown the entire X-ray. It is showing only one half of the X-ray. You can see the hyperlucent and the more dark black shadow. Are there any vascular markers seen here?
No, sir. Collapsed lung, sir.
The pneumothorax.
Pneumothorax.
In the chest X-ray, in the CT, and there is a barcode sign here. Okay? So comparison of chest X-ray, CT chest and ultrasound in pneumothorax. Okay? So all the three have been compared. So we are showing here a blood-brain barrier. Okay. What is a blood-brain barrier? What are the components?
A tight junction created.
You can see this picture. There is a blood here. That means this is a blood vessel wall. And this is the astrocyte food process. This is the gut junction. So, the physiological barrier between the blood and brain tissue, which restricts transfer of molecules from plasma to the brain. Okay. And what constitutes the blood-brain barrier? These cells, what are they?
Endothelial cells.
Endothelial cells.
And this is a basement
capillaries.
membrane, and this is the food process. Okay, so endothelium, basement membrane, and astrocyte food process. What is the function of blood-brain barrier?
Allows only selective movement of molecules from.
Protection of brain from endo and exogenous toxins. Provide tight control of the ionic concentrations of hydrogen, sodium, potassium, calcium, magnesium, to which brain is very sensitive. Protect brain from transient changes in plasma glucose levels. Prevent release of central neurotransmitters into systemic circulation. Which pathological conditions affect the integrity of blood-brain barrier?
In,
Neuroanesthesia particular, meningitis, acute and chronic hypertension, epileptic seizures, multiple sclerosis, Alzheimer's disease, all these things. Even some large tumors, brain tumors also can affect the blood-brain barrier. That is why we give dexamethasone to stabilize the basement membrane integrity. Okay, as a part of the treatment. Which parts of the brain lie outside the blood-brain barrier and why? There are 5 parts lying outside. Area postrema, median eminence, pineal gland, neurohypophysis or posterior pituitary and choroid plexus. Okay. And area posterior is also known as vomiting center. It protects from toxins entering the blood. Then 2 and 4, that is median eminence and neurohypophysis, cause anterior and posterior hormone secretions into the blood. And pineal gland secretes melanin, which is important for circadian rhythm. What is being done here?
Vestibular.
Apnea test.
Apnea test is here.
Checking the
called?
cranial nerves for brain death.
Yeah, brain stem death is being tested. Number 1 here, the painful stimulus response by pinching the tip of the finger and the glabellar pressure. These are all supposed to be the or pressure over the sternum. They are all considered as the most painful stimuli to elicit pressure and brain response. Second is examination of the various cranial nerves. Third is apnea testing. How is brain stem death defined? What is the definition?
Irreversible
Irreversible loss of consciousness and ability to breathe. Okay, defined as
respiration.
irreversible loss of consciousness and irreversible apnea. Simple to remember. What factors exclude patients from undergoing brainstem testing? All things that
Unstable hemodynamics, sir.
okay. Factors na knowledge also. First is should be not having hypothermia is contraindicated. Core temperature should be more than 34. No metabolic or endocrine disturbance. No depression drugs or neuromuscular blocking drugs. Cannot perform patients with paralysis and syndrome body syndrome. What is the definition of legal time of death? How many times you should do the brainstem testing?
Twice 6 hours
Twice.
apart.
4 to 6 hours apart.
So after the first testing, if you declare the patient as brain dead, that is called the legal time. Even though you do a second testing after 6 hours, once the decision that the patient is brain dead is made after the first testing, that itself is called the first legal time of death. What additional tests are done and why are they done? Sometimes we just don't stop with this. We may need to do some extra testing.
If it is indeterminate, we'll do cerebral angiography, cerebral scintigraphy, sir. Ancillary brain test will do, sir.
4
EEG.
vessel angiography, CT/MR angio, transcranial Doppler, EEG, and auditory evoked potentials. They are done in cases of lung disease preventive apnea test, in cases of craniofacial injury, where cranial nerve testing is not possible. So these are the indications. Shall we stop here? It's too much time.
Yes, sir.
Yes, sir.
Yes, sir.
We have the